Okay. Now then, you take. Right, take two. Okay guys, I'm going to be talking to you about trauma and orthopaedics, and hopefully this time it will work and I'll not break it. So what we're going to cover are your ACT conditions. I'm sure you've all seen your handbook, whether you've looked at it in much detail, I do not know, it doesn't matter yet. They are your 4 ACT conditions. That basically for ACT conditions you need to know how to initiate appropriate action, how to prescribe, and when to get help. So they're the most important things to know. The other section is list 1, and they are all covered in that. Let's move that up there. So we'll briefly be looking at some of those things, and then the no-op conditions, which are list 2, are those which, if you're looking at you doing well, can't say I really did. Okay, so does anybody know when you'd be doing this at all? Excellent, good stuff. So yeah, that's fasciotomy essentially. So compartment syndrome is one of your ACT conditions. So basically this is a surgical emergency. If you suspect it, you need to be getting help quickly. So let's go back. Does anybody want to tell me what compartment syndrome is? Hazard a guess. Yep, that's exactly right. So basically anything that can cause the pressure to raise causes too much pressure within the compartment, and basically if the pressure is above the capillary pressure, this causes reduced capillary flow, so all the waste products essentially can't be transported out of the compartment. That causes the cells to basically become deprived of oxygen and can cause the muscle cells to die. What can cause compartment syndrome then? What would cause that pressure to be raised? Yep. What is it about the fracture that causes it? Yeah, exactly. Anything else? Yep, burns is a really good one, really important one. So if any patient comes in and they've got loads of burns and their arm's really painful, then that's something you need to suspect. Anything else? Excellent. I'm doing your revision. Anything else? They're kind of the main ones. So yeah, anything like crush injuries, fractures, like you said, any kind of trauma basically. Any edema as well can just cause it, anything that's causing that increase in pressure. Okay, and what are the common symptoms? How are you suspecting the patient's got compartment syndrome? Yeah. Anything else? Pardon? Yep. Anything else? Yep. Anything else? So the main big ones are pain, as you said, but it's pain that's disproportionate to the amount, to the injury, whatever they've had. So if they've got a really, really painful calf and you don't really know why, that's one thing to suspect. The other thing is pain on passive stretching. So if you get them to lie down and you just bend their foot up and it's really, really painful, then again you need to suspect it. So often their limbs pulseless and it's white, but that's a really late sign, so if it gets to that then you're worried. But the other things are like redness and tightness as well. Okay, so what are you going to do about it? What investigations are you going to do? How are you going to make a decision that this is compartment syndrome? Anyone? Come on. Yep, excellent. So yeah, it's basically to diagnose it officially you need to measure the pressures. Now the pressures should be your diastolic minus the pressure. If that's less than 20, you probably don't need to know this. Basically, then that means they need a fasciotomy essentially. I wouldn't worry too much about the numbers. Basically, you measure the pressures. One of the things that you should do is measure the pressures in all the compartments. So if you're doing it in the car, measure it in all the different compartments, because you can have compartment syndrome in them all, and if you're treating one and the other one's still got raised pressure, then you've not really solved all of the problem. So what else are you going to do? If you're suspecting this patient's maybe going to need to go for surgery, what other things are you going to do? Just your basic things. Yep. What other investigations? Yep, bloods. What bloods do you think are relevant? So one of the quite important one is CK, which is a measure of muscle breakdown essentially. So if a patient's had compartment syndrome, they might have rhabdomyolysis, so you need to check the CK as well, because if that's going up, you need to flush that out because it can cause loads of damage to the kidneys, so you need to be giving them fluids, and yeah, basically like treating that as well, just stop them from having an acute kidney injury. But yeah, other really important things are like telling the theatres, getting the surgeon involved and things like that. So yeah, urine myoglobin as well, that's basically a measure of muscle breakdown. Other things, obviously, just your basic management. If anyone needs oxygen, whack that on as well. And as you mentioned before as well, if a patient comes in with a cast on, then cut that cast open and see, because that might be enough to just relieve the pressure without them having to have a fasciotomy. So in terms of your management, it's your standard ABCD, which I'm sure has been drilled into you like crazy, and other things like giving them the fluid, potentially urine alkalinase. I'll make them urine more alkaline, because if they've got rhabdomyolysis, that can cause the urine to become quite acidic. But again, that's kind of above, don't worry about that. But the most important thing that you do is you get help. Like, this is beyond your realm. If you recognise this, you need to be getting in touch with like your seniors and other teams as well as soon as possible. Like, you can do the basics, but you're not going to be expected to treat this on your own. So a patient comes in with that painful swollen calf. What are your other differentials? What else have you got to be thinking about to rule out? Yep, excellent. Anything else? Yep, definitely. Anything else? I guess just other things like it could just be a normal fracture and not have compartment syndrome on top of it. But yeah, you got the main one. Excellent. Right, what do you think this is? Yep, excellent. Any other differentials if you saw this in a patient? Yep. Excellent. Anything else? Yep, trauma. And one other one that you mentioned for the other one? Yeah, exactly. So yeah, red hot swollen joint is your main worrying thing is septic arthritis, but they're all your other differentials as well, and you can basically find that from the history, what the patient says they've come in with and things like that. So, septic arthritis. Anyone hazard a guess at what it is? Essentially, yes, correct. So it's an infection within the joint. Either somebody has stuck something into the joint which has caused an infection, or they've got an infection somewhere in the blood and that's caused it to spread to within the joint. Most commonly it's usually staph or strep bugs. I wouldn't worry about what actual bugs it is in particular. They're just the most common ones, as they are with most things. How are you going to recognise it? Excellent, yep. Other things are patients often got reduced range of movement just because the joint's really hot and swollen, and they'll sometimes have systemic symptoms as well, so they might have a mild fever or something like that as well. But yeah, they're essentially the ones. You can basically recognise a lot of it just by looking at a picture like that. So what are the main risk factors or causes of it? Yep. 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 Anything else? IBDUs, yep. Yep, absolutely. I think you've got most of them there. So yeah, prosthesis. Any diabetes is a massive risk for infection for most things. Any joint injection, anything that's gone into the joint, any trauma or anything that's caused that will increase your risk of septic arthritis and make you a bit more suspicious of it. So what investigations are you going to do? If you're all quick enough, you'll look at the answers before I take it off. Yep, exactly. So there's infection in the joint, you need to get it out before, like antibiotics will do so much, but you essentially need to get that out of the joint. What else are you going to do? So you've got an infection, what are you going to do with an infection? Exactly, yep. So yeah, you want to find out the source of the infection so that you can treat it more specifically. And after you've taken blood cultures, what usually goes with that? What are you going to give? Exactly, yeah. Cool. So there are most of your infections. Obviously, your standard set of bloods, find out what's going on, look at your marked inflammation. But the aspiration is really important to do that before you give them any antibiotics, so that you know exactly what you're treating. And equally with the cultures, get an X-ray as well, just to check there's no osteomyelitis or anything like that going on in the joint. And then in terms of your management, you want to be doing the joint aspiration and wash out first with the blood cultures as well. then you need to give IV antibiotics after that. It's important to give the antibiotics after. In terms of knowing antibiotics, I wouldn't worry too much about exactly what you're going to give for everything. Don't worry about doses in fifth year, it doesn't matter. Like, have a rough idea of what you might treat something with, but then you can always follow it with, and I would look up the trust guidelines. Like, that covers you back for everything, because that's essentially what you need to do, and that's what you do as a junior doctor. You like have an idea of what you would roughly treat with this. So for this, it's usually going to be the flu clox, but don't get like stuck up on knowing what antibiotics treat everything. It's really not that important at this stage. Okay, but yeah, again, important, get help. You're not going to be dealing with this on your own. You're not going to be doing the washout of the joint, so get help as soon as you can, because if this is left, the patient can essentially like get osteomyelitis in the joint. The worst can happen is they can die if it suddenly becomes really septic. So it is quite a serious thing. Okay, what do you think this is? Say it a bit louder. Exactly, yeah. So you can just see that compression coming in there on the spinal cord, and it's pretty easy to detect. You can just basically see it's not all nicely lined up or anything at the moment. Okay, so what is spinal cord compression? Kind of as it says, it's anything that compresses on the spinal cord, usually caused by like some stretching or something like that. It can be for like, or any damage to the spinal cord. Basically results in some loss of motor and or sensory functions at the same time. So it can compress any part of the spinal cord. So at the level of the compression, you get upper motor neuron signs, and anything below that level, you get lower motor neuron signs. So these are the main causes, anything that will cause a compression, so whether it's a malignancy, any trauma or fracture, or anything causing any compression on the spinal cord. How are you going to recognise it? What signs are patients going to come in with if you're suspecting spinal cord compression? Yep. 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 And with that, you often get taught that it's always one way round. But to be honest, anyone that is newly incontinent in either area, just be a bit concerned, or in retention, either constipated. Don't be concerned about everyone that has constipation, but if it's kind of abnormal, like this is how they normally present, but it can be kind of either way. So don't just rule it out based on that. Yeah. Any others? So you also get the saddle anesthesia, any kind of sensory changes or motor function changes, just think about it. So yeah, they're the main ones. Okay, what investigations are you going to do? Yeah, correct. That's the most important thing. So it's got to be like diffusion weighted MRI or something. But before you even do that, you're going to be talking to somebody before you do. But basically that's how you're going to diagnose it. And again, like if you're suspecting any infection that's caused this, if you think it's some kind of an abscess in the back and the patient's unwell, take blood cultures as well to try and like direct the antibiotics. So in terms of your management, what are you going to be doing? Yep. Anything else? Yep. So if they're in any pain, yeah, definitely analgesia. So basically, if you're suspecting spinal cord compression, you need to immobilise the patient. They need to be like with head collar straps on and really seriously immobilise them so they can't move and cause any further problems. If it's a malignancy, you write with Dex. If it's an acute thing, they sometimes get IV methyl press, but again, don't worry about it. I just stick with Dex for you guys, and you're not really going to be doing that on your own either. So yeah, get help, get a neurosurgery review urgently. Like this needs urgent surgery because otherwise they can lose a lot of function. So you need help. As with all of these. Okay, they are. Oh, one more. What's this one? Sorry, a bit shitty picture, but yeah, temporal arteritis. So, what is it? Yep, correct. So it's just basically an immune-mediated vasculitis, either large or medium vessels, and typically it happens in the branch of the external carotid, so that's why they often get it on the side of their face. Okay, so how are you going to recognise it? What is the patient going to come in and say that they're having? Yeah, okay. Whereabouts? Yep. Yep. Scalp tenderness. Yep. Yep. So you often get jaw claudication with it as well. Yep. Pardon? Yep. Yep. Visual loss as well. Yeah, and it's always painless as well, so that's important. Yep. So you've got most of those. Sometimes they can have a little bit of a fever as well, but to be honest, you've got most of the most important ones like the tenderness and things like that. Okay. So what are you going to do in terms of investigations? Yeah, so that's essentially the most important investigation for diagnosing it. You need to do a temporal artery biopsy, although if it's negative, that doesn't always rule it out, because with any biopsy you might not get the correct sample essentially. So you're going to do all your normal bloods and things like that. They also do ESR, which if that's raised over 50 millimeters per hour, then that's kind of one of the diagnostic factors as well. There's various diagnostic criteria. They are, which I don't think you need to worry about, so don't, but I'm just going to tell you, basically, over 50 years, new onset of headache, tender there, reduced pulsation, elevated ESR, and the abnormal biopsy. Obviously, the abnormal biopsy, if that's positive, then you've got a diagnosis right there, and that's your best one, really. But you often will still have to treat it regardless whether you've got that and you've got some of the other things. So what are you going to do in terms of management? Correct. So that's really, really important to get them in as soon as possible. So basically they have to go on a fairly whacking dose of prednisolone for quite a long time, and as you may or may not know, basically going on long-term steroids degrades your bones essentially, so it's really important to give bone protection as well. They need to be on calcium supplements and alendronic acid as well. So if you get anything like this, that's just anything with steroids, kind of always think of bone protection. It doesn't matter if people are going on it for like just a short course, but when you're on it for months and months, it is really important, especially in little old ladies that are going to fall and fracture their hips and things. If they've had any visual loss as well, just get an ophthalmic review, but more importantly, get help. Okay, right. Anyone hazard a guess as to what this is? Yeah, exactly. So you can tell because this patient has got a shortened and externally rotated left leg. So that gives you a high suspicion of fractured neck of femur. Anyone know about the classification of hip fractures or the different types? Yep, so intracapsular and extracapsular. So the intracapsular ones are just that little shaded section. Extracapsular are all the rest of the ones around that side, down there. So what's the big concern with the intracapsular ones? Yeah, exactly. So you've got a blood supply that comes through the head, the femoral head. So basically, if you've got a massive cut through that, that's going to compromise the blood supply, and essentially they're going to have far more complications than if it was just an extracapsular one. So basically for intracapsular, there's a classification called Garden classification, which puts it into 4 different categories, as you can see on this. So 1 and 2, you can see the head isn't massively displaced. And some patients that have a fracture like that, if they're just little old ladies that are really not fit for surgery, if you leave that, it may well heal itself and kind of just remain stable, just given like 6 weeks of immobilization or whatever. But 3 and 4, they've been displaced, and those ones won't heal by themselves, so they need surgery essentially. There's a little rhyme to remember the management for them. So it's 1 and 2, use a screw. So for those ones, you can just stick a screw through it. 3, 4, often more. Often more is a hemiarthroplasty, that somebody invented. So basically for those ones, 3 and 4, they need a hemiarthroplasty. If they are relatively young patients, sometimes you can use reduction in internal fixation, but that's just the general one for the intracapsular ones. Now for extracapsular ones, that's basically any break that's down here. They will need they need dynamic hip screws that basically just like work by being able to move within the joint. Okay. Can anyone spot which side the fracture's on? Excellent, yeah. So you can kind of all see it. Basically it looks a bit asymmetrical. That one looks a bit pushed up and kind of doesn't have as much space. The relative, like an obvious one is fine to pick up, and you wouldn't get asked to do anything more than that. Like they wouldn't give you a really difficult one and ask you to identify that at all. Okay, back pain. Briefly cover this. Do you want to shout out some red flags for back pain? Yep. Yep. Mm-hmm. Yep, so any neurology really covers that. Any others? Yep, that kind of goes with the neurology as well, any neurological changes. Yep, absolutely. History of trauma. History of trauma would probably explain the back pain more than anything. So probably not for the trauma. Right, they are the main ones. So if they're really young or much older, then it's a bit more of a worry. I guess if they're much older, you're kind of worrying about any metastases. Non-mechanical ones, so if patients don't really have any reason that the back pain's just suddenly started. If they're on steroids, again, you're worried about the strength of their bones and things. Weight loss, you're worried about cancer as well. Neurology as well. So don't need to worry too much about this, but this is basically just a little table to kind of say, in these age groups, these are the most common causes for the back pain. So mainly, your main ones like postural for the majority of the age groups, and obviously degenerative changes and things like that. The most important thing with back pain is if there aren't any of the red flags, you need to be ruling out anything that's more serious. If not, like, you can just give them general advice. That's basically things like regular exercise, get good weight, give them postural advice, lifting techniques, any correction in leg length discrepancies, because that can cause a lot of back pain as well. This slide just kind of goes through the different types of fracture. I don't know, basically it might just be worth you being aware of them just to kind of recognise what they all are, just because if you get given an image you want to be able to roughly describe a fracture. Do you want to go through it from this up and across, what they all are? So what's the first one? Excellent. Second one? Yep. Next one? Yep. Next one? Yep. And then the other one? Comminuted? Yep, well done. And the bottom line? Someone said it, go on, say it with confidence. Yeah, well done. The next one? Chipped is definitely the technical one. Avulsed is what that one is. And the other one? Basically that one, it's an impacted one, so it's basically a bit of it being pushed into the other section. You don't need to know the other one, it's called torus, never heard of it, doesn't matter. And the last one? Greased it, yeah, excellent. So it's just like if you get a fracture, it looks better if you can roughly explain what's going on with it. And saying avulsed probably sounds a little bit better than chipped, but I like it. Okay, cool. Do we know what Colles and Smiths are? Does anyone want to hazard a guess at telling me what they are? Yep, definitely. Basically, it's a fracture of the distal radius. In Colles, it's when you fall on an outstretched hand, so you fall like that. In Smith, is when you fall on your hand like that. And depending on which way you fall, the X-ray from the X-ray you can interpret which one it is. So does anyone want to guess which one this is? Colles, yeah, because you've fallen like that, so your hand's pushed that way, so on the X-ray, your hand is up from the rest of the bone. So if you've fallen like that, then your hand is inwards and the bone's pushed upwards from your hand. Probably wasn't the best way of explaining it, but you all seem to know which one's which, so that's good. Cool. That one's real. Okay, so these are my wise words to you all. Know your ACT conditions really well, like look through that list. You want to know what you need to do with those, what you need to prescribe and when you need to get help. And generally it's a lot of the basic stuff, and just know that it's important to get help for a lot of them, because especially with these ones, these are like surgical emergencies and things, and if you can't deal with them on your own, if you don't get help, your patients could die. Know your list 1 conditions quite well, like they can come up in the MCQs and things like that. Maybe look at list 2 if you have time. I literally briefly skimmed it and was like, not really heard of most of those, I haven't got time to worry about it. They didn't really come up that much and I passed, so it's fine. Practice OSCEs in groups, like you just can't do it on your own, you can't talk to yourself, you can hear how you sound, but when you're talking to somebody else, it brings out so many of the little things that you say and the little niggles with it so much easier, and it just makes it a bit more interesting, especially after you've just done your finals, like you just can't be bothered anymore, you need that little bit of inspiration. So yeah, that is my wise advice. Any other questions? Excellent. Cool. Thanks guys.